all our questions. Lots of great questions, and thank you for such an interesting talk. And I think with that, we will transition to our next speaker. So I have the honor of presenting both my friend and colleague on the West Coast, Dr. Victor Huang. Dr. Huang is the director of both the Vitiligo program and phototherapy at the University of California, Davis in Sacramento. And so today he will be speaking with us about an open label pilot study of Abatacept for the treatment of non-segmental vitiligo. Thank you, Dr. Huang.
To be part of the Vitiligo International Symposium this year and having the opportunity to present some work that was done at the Brigham and Women's Hospital in Boston, an open-label pilot study of Abatacept for the treatment of non-segmental vitiligo. By way of disclosures, this study was conducted with the support of Bristol Myers Squibb, and off-label indications will be discussed. Vitiligo is a common condition marked by the destruction of melanocytes. A number of observations, both clinically as well as in the research setting, implicate the immune system as a primary driver for the development of vitiligo. GWAS studies have implicated genes that are important for innate and adaptive immunity, and clinical observations of higher rates of autoimmune comorbidities, including thyroid disease, psoriasis, lupus, and rheumatoid arthritis, suggest that the immune system is important for vitiligo pathogenesis. Finally, patients with melanoma treated with immunotherapy often develop vitiligo-like depigmentation. In particular, patients treated with ipilimumab, a CTLA-4 antagonist, develop vitiligo-like depigmentation in about 15 to 20% of patients. Further work by a number of different groups have implicated the T cell as the cell responsible for vitiligo-like phenotypes. Indeed, the number of CD8-positive T cells in histologic specimens or in lesional blister fluid is associated with vitiligo activity. Multiple groups have also reported either decreased Treg numbers or decreased Treg function as being important in the pathogenesis of vitiligo. As CTLA-4 expression by regulatory T cells are an important mechanism by which they exert their inhibitory functions, CTLA-4 agonists such as Abatacept were an attractive target. As a brief primer on T cell activation is dependent on the T cell receiving two signals. One mediated by the T cell receptor engaging with antigen presented by MHC molecules on antigen-presenting cells, and a second signal that is mediated via B7 interacting with CD28. CTLA-4 acts as an antagonist of this second signal by interrupting the engagement of CD28. Abatacept is a soluble CTLA-4 molecule that, when presented in excess, will prevent the activation of T cells. Alternatively, ipilimumab, which is an antagonist of CTLA-4, removes CTLA-4's ability to antagonize T cell activation. For these reasons, inhibiting T cell activation using Abatacept seemed like a promising therapeutic approach. So we embarked upon an open-label single-arm pilot study and requested that all of our patients wash themselves out of any prior treatments they may have received for their vitiligo. While on protocol, no concomitant treatments were allowed, and we recruited patients who had non-segmental vitiligo who reported new or expanding lesions within the last 6 months in an effort to capture folks with more active vitiligo. Greater than 5% body surface area was required, and patients were treated with Abatacept 125 milligrams sub-Q weekly over the course of 24 weeks. As a primary outcome measure, we selected body surface area involvement as measured by the Vitiligo Area Scoring Index. As a secondary endpoint, we selected a disease-specific quality of life tool known as VitiQual. 9 out of 10 of our patients completed the study, with 1 patient lost to follow-up. Overall, 3 patients were female with 7 males. The mean age was 46 with a range of 28 to 59. The mean initial VASI was 19.5 with a range of 4.5 to 54. And all patients had failed previous therapy with topical steroids, phototherapy, or mini punch grafts. While there was not a significant change in overall VASI, there was a trend towards improved VitiQual scores, in particular in the participation limitation domain that was captured therein. 3 patients did experience resolution of some lesions, 2 of whom experienced meaningful improvement of facial lesions. Here displayed are some representative images of the patients at week 0 and at week 24 with the concomitant improvement of their facial lesions. A third patient experienced a resolution of a lesion on his chest that interestingly was associated with a trip to Vegas and sun exposure by poolside. In terms of adverse events, for most people the medicine was well tolerated. Local injection site reactions were common but did not require dose reduction or cessation. 1 patient was diagnosed with a marginal zone B-cell lymphoma 4 weeks after completing the trial, however. As a pilot study, our protocol did have several inherent limitations. The patients were small in number and relatively uniform, both in terms of ethnic as well as socioeconomic background. To maximize safety, our protocol included treatment with Abatacept 125 milligrams sub-Q weekly over 24 weeks without a loading dose. The experience for patients being treated with rheumatoid arthritis and psoriatic arthritis suggests that including that loading dose up front may yield quicker and more consistent results. Finally, all of our patients were examined without any concomitant treatments. The experience with topical and systemic JAK inhibitors suggests that narrowband UVB or UV exposure can have synergistic effects with immune modulation. This is interesting in light of our patients experiencing the greatest effect on the face, which is relatively photo-exposed, as well as our third patient experiencing a resolution of a lesion after noted sun exposure. Finally, I'd like to acknowledge the friends and colleagues who made this study possible. Vanita Sheth, Joe Marola, and Christina Liu are all colleagues at Brigham and Women's Hospital, and without their help and enthusiasm for this project, this could not have been accomplished. Thank you very much for your help.
Well, thank you, Dr. Huang, for that very interesting presentation. So we have a couple of questions here. Do you think there's a role for Abatacept for maintenance of response?
Yeah, I potentially. So I think that a number of presentations earlier yesterday, as well as that have been published in the literature, have demonstrated the importance of maintenance. And this would offer a different mechanism by which we could potentially provide that maintenance therapy over time to minimize the risk of recurrence.
Okay, thank you.
Yes. All right.
We have a question from
questions. One about the Yes. One about poliosis. Did the patients have poliosis, and another about activity?
Yeah, I think it's a really good question. We tried to we didn't systematically record where there was poliosis. We did note that several of our patients did have poliosis. However, none of them had greater than 30% poliosis in any given area or for any given lesion. But we didn't systematically look at that, which was an oversight on our part in the study design. I think the other question with regards to activity is a very important one. We tried to get at that by only including patients who self-reported either new lesions or expanding lesions within the last 6 months. But we know now from work that's been done by Dr. Pandya that patient self-report of activity is not very reliable. And so, in future studies and for other studies, having a more rigorous criteria for the definition of active vitiligo will yield a more homogeneous group of patients, certainly.
Okay. There was also a question about whether you had the chance to check levels during the course of the treatment of the T regulatory population in the blood and or the skin in the patients treated.
Yeah, that's a really interesting question too. So this protocol was put together primarily for the clinical part. So we didn't have very much in terms of biomarkers and additional laboratory examinations for the patients. The labs that were drawn during the course of the protocol were used primarily for safety monitoring. But that would be a really interesting question as well.
Great. Thank you so much, Dr. Huang. I think we're out of time, so I'm going to pass the mic to Dr. Salim to introduce our next speaker.
Thank you, Dr. Nata.
Thank you.